Now let's talk about the mechanism of action of the different drugs to treat patients with diabetes. And before we go into too much detail, let's first put them all onto this figure so that we have them all on one sheet. So I want to start with the drug metformin. And metformin is a very old drug, very effective, very also cheap. And what it does, it affects a kinase, AMP kinase. And what is interesting is that metformin kind of does, in part, similar things than insulin does. It actually, the signaling pathway of AMP kinase converges with insulin signaling. So we can put metformin somewhere here because you can almost see like downstream this AMP kinase converges with signaling of insulin receptor, and it also helps to upregulate GLUT4. It also helps to upregulate GLUT4 in skeletal muscle and adipose tissue, and it also going to decrease glucose production in the liver. So that's why I put it like here, because you can almost see it kind of downstream insulin signaling. Now we have another drug class that also has a completely different target, but we can also consider it working as a what's sometimes referred insulin sensitizer, like making insulin work better. And these are the TCDs, the thiazolidinediones, things that end on glitazone. And they have a nuclear receptor as a target, but also we can consider as converging with insulin signaling downstream. They also affect gene transcription. So their target is a PPAR alpha receptor. They affect gene transcription, and then they're also going to activate AMP kinase. So you can see that signaling converges. They also lead to shutting down glucose production in the liver, increasing GLUT4 on skeletal muscle. So that's why I put them together. They have different targets than insulin, but in the end there is some conversion of the signaling, and they also help insulin work better. Then we have drugs that directly act at the pancreatic beta cell, and these are our sulfonylureas. They are also non-sulfonylureas, but they work very similarly. What they do is just shutting down the potassium channel. And remember what's going to happen when you shut down the potassium channel. Well, insulin is going to be released because you accumulate positive charges, and then the calcium channel is going to open and facilitating insulin release. So instead of our way of making ATP, which shuts down the potassium channel, they just shut it down from the outside. So these are our sulfonylureas. Then we have other cells that directly act at the pancreatic beta cells, and these are a very important drug class. These are our GLP-1 agonists, and it turns out that this GLP-1 receptor also sits on the pancreatic beta cell. It sits also on other cells, and I'm going to get to this when we discuss them in more detail. So these are our GLP-1 agonists, the tides, things like semaglutide, exenatide. And what they do is they act at the GLP-1 receptor, a G protein coupled receptor, as you can see here with my wiggle, and it's actually GS coupled. When you're going to have increased levels of P as a consequence of the GS stimulation, you're going to activate PKA, and this is going to help open the voltage-gated calcium channel. But I just want to point out that it helps this process better. This doesn't mean it is independent of glucose, and that's going to be very important when we are discussing differences between these drugs, because it just makes this open up better, but not independent of any glucose. And then we're going to also get increased insulin release, in addition to many other things they do. So these are the GLP-1 agonists. So it turns out that GLP-1 can be broken down by an enzyme called DPP4 to metabolites. And we just discussed, at least in part, what GLP-1 does, for example, stimulating the GLP-1 receptor, which helps open up the calcium channel better, leading to insulin release. And GLP-1 is actually glucagon-like peptide 1, which is produced in the gastrointestinal tract, and it is broken down by DPP4, so we can use drugs like DPP4 inhibitors to have less breakdown of GLP-1 and increase basically the levels of GLP-1, and so that GLP-1 can do its job. The ending of this DPP4 inhibitors is gliptin, so things like linagliptin, sitagliptin. Now, in order to put in one more drug class on this favorite figure, we have to now also consider the kidney. We know that the kidney also influences our glucose levels, and we reabsorb glucose in the kidney via a transporter called sGLUT2. This is sodium glucose transporter, and it takes back sodium with glucose. So we have drugs that inhibit this. These are our sGLUT2 inhibitors. They end in gliflozin, which basically means keep the glucose flowing, because you inhibit the reuptake, so you keep the glucose flowing out, and that's their mechanism of action. So I think we have now put in here all the important drug targets that we're going to now discuss in more detail. And so we started with drugs that we say converge with insulin signaling, like metformin and the glitazones, and also realize there's a lot of glue in the names of the drug that can help you to remember what they're used for. So these are the TCDs, metformin. And then we said there are sulfonylureas, which just independently from what we eat, they just shut down the potassium channel and help us to release insulin. Then we talked a bit about GLP-1, this important receptor that also sits on the pancreatic beta cell and that can be targeted by the GLP-1 agonist, the TIDES. We can also just block the breakdown of GLP-1 with the DPP4 inhibitors, the gliptins. And we can go to a completely different organ, which is the kidney, and prevent the reabsorption of glucose by blocking sGLUT. And these are the gliflozins, and that way we keep the glucose flowing.